Next, we have Bariatric Centers of Excellence, the effect of centralization on access to care by Lindsay E Kuo from Hospital of University of Pennsylvania.
Thank you for the opportunity to speak this afternoon. This research is funded by a grant from SAGES. We have no other financial disclosures. In 2006, Centers for Medicare and Medicaid Services restricted coverage for Medicare patients for bariatric surgery to designated centers of excellence. These centers were deemed so because they met minimum volume standards and certain quality metrics. This decision was known as the National Coverage Determination, or NCD, and has since been rescinded. However, the rationale behind centralization of care and coverage restriction is that higher volume centers often result in better surgical outcomes. And while this conclusion is yet to be finalized for bariatric surgery, the effects on access to care have not fully been studied in the literature. The small literature that exists following the NCD indicates that in a subpopulation, minority Medicare patients experienced a relative decline in the proportion of bariatric surgery cases, and in one healthcare market in Texas, all Medicare patients experienced an increased travel distance in order to access their bariatric surgery. Because Medicare coverage decisions can affect private payer coverage decisions, and because coverage restrictions can exert market forces that are otherwise unintended, we sought to examine the bariatric surgery model and the access of all patients, regardless of insurance status, to bariatric surgery. To do so, we used two state inpatient discharge databases, Florida and New York. These are both high-volume surgical states. We chose 2 time points to study. The more proximal time point was 2008, and this was chosen to allow for at least 1 year of full NCD coverage before the study began. 2011 was the end time point, and this was chosen because at the time we obtained our data, this was the most recent data available. All obese patients aged 18 or older who received bariatric surgery were included in the study, and the 2 states were divided into health service areas to understand geographic distribution. Health service areas are geographic locations in which health care is relatively contained. The characteristics of patients undergoing bariatric surgery throughout the time of the study period were examined, and non-parametric tests for trend were performed. We also examined rates of bariatric surgery per 100,000 obese residents to examine the performance of bariatric surgery in relation to its need, and compared this between Center of Excellence institutions and non-Center of Excellence institutions, and Medicare and non-Medicare patients. In 2008, there were 44 centers of excellence, and these were distributed amongst 21 HSAs out of 38 total of those 2 states. In 2011, there were 67 centers of excellence, and these were distributed amongst 22 HSAs. No HSAs lost a center of excellence over the time period studied. 27 HSAs, again out of 38 total, experienced no change overall. 6 HSAs gained 1 center of excellence, and notably, 1 HSA gained 6 centers of excellence. In 2008, there were 13,000 bariatric surgical procedures performed, and this number decreased over time to 2011 to just over 11,200 performed. The proportion performed at centers of excellence increased over the time period from 60% in 2008 to 73% in 2011. This was statistically significant. The proportion of bariatric procedures performed on men was similar throughout the time period, although there was an increase in the proportion performed on African Americans and Hispanic patients. There was also an increase in trend towards people who had Medicare or Medicaid as their primary payer receiving bariatric surgery, and a relative decrease in the number of patients who were uninsured or who self-paid for bariatric surgery. There was also an increase in the number of comorbidities obtained by the patients who had bariatric surgery. You can see there that the number of patients who had at least 3 comorbidities increased from just over 22% to 27% in 2011. When you examine the number of procedures performed based on where patients resided, the vast majority of procedures were performed on patients who lived in metropolitan areas, 91% throughout the entire study period. Less than 1% were performed on patients who lived in predominantly rural areas. And when you examined the average distance in miles traveled by patients to obtain their bariatric surgery, there was no change in time throughout the 4 years we studied. Again, we examined bariatric surgery procedure rates per 100,000 obese residents in the areas surrounding the hospitals, and we again found that there to be a decrease in the number of procedures performed over the 4-year study period. Much of this decrease appears to be attributed to in hospitals that were not centers of excellence. You can see there that there's a significant downtrend over the 4-year study period, as well as in the patients who reside in metropolitan areas. When we examined the percentage of bariatric surgery patients who were minorities and receiving care at centers of excellence versus non-centers of excellence, African American patients are represented in the yellow and the red lines there. The red indicates Black patients who received care at centers of excellence, and the yellow at non-centers of excellence. So there's an overall increasing in trend, as we mentioned before, in both populations, with a significant increase still at non-center of excellence institutions, and similarly for Hispanic patients. When we examined the minority patients receiving bariatric surgery who had Medicare and non-Medicare, you actually see that Black patients receiving Medicare increased far more than the patients who are not on Medicare. Travel distance was very significant. All the values that we are showing are statistically significant. For patients residing in metropolitan areas, their travel distance was relatively low. You see here the red indicates if they were going to a center of excellence, the yellow a non-center of excellence institution, green if they were on Medicare as their primary payer, and blue if they were not. So metropolitan patients had a relatively low travel distance. Urban patients had a moderate, but rural patients had a fairly high travel distance. And for those patients who were going to a center of excellence, their travel distance was far greater than those who were not going to a center of excellence. And for those who were on Medicare, they also had to travel far more than those who are not on Medicare. So in conclusion, we found that centers of excellence are not widely distributed geographically. Despite the fact that the 23 centers of excellence were gained over the study period, only one HSA that did not previously have a center of excellence gained one. The rest of the 22 centers of excellence that were added to HSAs that already had a center of excellence. The addition of centers of excellence did not lead to an increase in the number of procedures performed, even when examining the trend as a fraction of the obese population, again in comparison to the population that needed it. However, centers of excellence did perform a higher proportion of procedures, indicating that centralization did occur as a result of a coverage restriction. Lastly, an increased proportion of minority patients received bariatric surgery, both at centers of excellence and those who are on Medicare and not on Medicare. But continued high travel distances were seen for rural patients, particularly for Medicare patients and those going to a center of excellence. There were no overall improvements in the travel distance required for patients to obtain bariatric surgery despite the addition of 23 centers of excellence, indicating that policymakers must incorporate geographic factors into their policy decisions in order to not disenfranchise those rural patients. Thank you.
Open for discussion.
Dr. Moriyama.
Yeah.
So you showed centralization, but if I'm not mistaken, over that same time period, there really hasn't been any improvement in outcomes. So even though we have this trend towards centralization and center of excellence status for institutions, I don't really think there's been a dramatic change in the outcome. So is there any way to look at outcomes data in any of this, to look at this?
So we could look at outcomes data, and there's a number of studies that have looked at outcomes for centers of excellence versus non-centers of excellence, and I think there's a lot of differential conclusions that people have reached in terms of whether or not it's better to go to a COE or not. We really wanted to look at it to say what is happening to the patients as a result of this insurance restriction. You know, are surgeons all going to centers of excellence who are going to perform minimally invasive bariatric surgery or just any bariatric surgery? How is this affecting people's ability to obtain bariatric surgery as a result? And so we deliberately chose not to look at outcomes as an effect.
And I guess the second thing I would want to know, if you could pull out of the data, is were there hospitals in these HSAs who actually stopped doing bariatric surgery during this period? Because that would result if we drove the business towards the metropolitan COEs away from the intermediate-sized programs. Is there a way to look at that? Or?
There definitely is, and that's an excellent point, and we'll be sure to include that in the final production.
Thank you. Nicely presented.
Thank you.
Very nicely presented. Could you speculate as to why they're not distributed geographically?
My entire speculation would be without, having a basis in understanding policy decisions, but my understanding is that the Centers of Excellence were named such by the American College of Surgeons and the Metabolic and Bariatric Surgeons or Society, and it's just based on volume and outcomes or meeting certain quality metrics and process of care metrics. And so it was not necessarily an a priori decision to have them geographically located in certain areas, but it was all about what the hospitals were currently doing. And so again, it wasn't an advanced decision about where they were geographically located, and I think that's probably something that should be considered going forward if people are ever to make another coverage restriction.
Were
Were your HSAs population determined, or were they geographic determined?
They are geographic determinations. They are actually published by the MCI and Sierra databases.
So they probably vary greatly in population density. And can you speculate that perhaps there's a certain population density that's needed to support a COA that's just not financially worth it for a very small hospital and a very low-density population to start a bariatric program?
I wouldn't be able to give you an exact number. Another study we've done using the same data and looking at bariatric performance and HSAs had indicated that there's just some HSAs that don't do any, and that's, maybe that's fine in the long run, but when you look at the fact that there's 22 HSAs that have centers of excellence and 16 that don't out of those 2 states, that's probably a gap there that needs to be filled.
Maybe another way to ask that question is, are those 16 that do not have an HSA very low population dense HSAs?
I wouldn't be able to tell you that off the top of my head, but that may be a result of, maybe a factor of the lack of bariatric surgery for rural patients.
Okay, thank you.
Thank you.